Okay, so because we're a mentorship program, our presentation is going to be a little bit different in that we'll also be providing an opportunity to learn the background of how to critically appraise and present a journal club in addition to actually critically appraising the trial. So we'll start with the background. So what other studies have been done in the CKD SGLT2 inhibitor arena? So you have the Credence trial with Dapagliflozin looking at renal events in patients with diabetes and CKD. This trial was actually stopped after the interim analysis because there was an overwhelming advantage of renal and cardiovascular benefit in patients. So what is CKD? Chronic kidney disease is defined as kidney damage for 3 or more months as defined by structural or functional abnormalities of the kidney with or without decreased GFR or GFR less than 60 for 3 or more months with or without kidney damage. About 700 million people worldwide have CKD, and risk factors for CKD include hypertension, being of Asian, South Asian, Aboriginal, or African descent, family history of kidney disease, obesity, smoking, diabetes, and history of acute kidney injury. Diagnosis of CKD involves either a clinical presentation and or screening for risk factors, blood tests, urinalysis, radiologic assessment, or renal biopsy. It's crucial to identify the underlying causes and optimize the management of other conditions as well as modify the risk factors. And this is all via the KDIGO clinical practice guidelines. So what are SGLT2 inhibitors? The medication class of available SGLT2 inhibitors in Canada includes Dapagliflozin, Dapagliflozin, and empagliflozin. These medications are indicated for various conditions and effective as second-line therapy for type 2 diabetes and as additional agents for CKD and HFrEF. Common adverse effects of these agents include dyslipidemia, hypovolemia, nausea, dysuria, and UTIs. And there's also been reports of acute kidney injury, among which there have been reports of hospitalization and dialysis. All of these medications are used once daily in an oral dosage form. One can also apply for special authority coverage as well. So SGLT2 inhibitors work by reducing the glucose reabsorption capacity of the renal tubule, leading to a decrease in renal threshold of glucose. So for those of you who don't know, the RTG just refers to the capacity of SGLT2 transporters being saturated and glucose being excreted into the urine.
So now we're just going to back up a bit and discuss finding the background information pertaining to a journal that you may be appraising or presenting on. So to approach the background information, gathering as much crucial information as you can to your understanding of the subject area is super important. So most of the time, the background and introduction of the trial will give you some of the key points regarding the condition and the medication or the medications of interest. So to get a bit more information pertaining to the medication in regards to the line of therapy, other therapeutic uses, mechanism of action and adverse effects, Lexicomp is a great resource that we're probably all familiar with. So also if you've already covered the condition in the modules before, it also may be helpful to review your notes for context as well. So just going to talk about the trial that we're going to be reviewing today. So we have Dapagliflozin in patients with chronic kidney disease. So this was conducted over a 2.4-year period with 4,304 participants by Herspink and al. So it's published in the New England Journal of Medicine.
So now let's take a look at the PICO. So in terms of the population, our patient population consisted of the following average patient: a 62-year-old Caucasian male with the most common comorbidities being type 2 diabetes, cardiovascular disease, and heart failure. In terms of medication, the patients were also on ACE inhibitors or ARBs, diuretics, and statins. And if we take a look at the inclusion and exclusion criteria, the inclusion criteria consisted of both females or males aged 18 years or older, providing signed informed consent with or without diabetes with a GFR of between 25 to 75 at visit 1. The ACR was 200 to 5,000 milligrams per grams at visit 1, and they must have been receiving a stable dose of either an ACE inhibitor or ARB for at least 4 weeks prior to screening. However, participants who were documented as unable to take an ACE inhibitor or ARB were still allowed to participate. In terms of exclusion criteria, you can see here that there was quite an extensive list. So on the next slide, we just summarized or put the top 10 exclusion criteria that we thought were the most relevant, and we also bolded the ones that we thought really stood out. So there are some exclusion criteria that are true for most trials. So for example, contraindication to therapy or short life expectancy. However, key exclusion criteria to this particular trial included those that had type 1 diabetes, class 4 heart failure, MI, unstable angina, stroke, or transient ischemic attack within 12 weeks prior to enrollment, and coronary revascularization within 12 weeks prior to enrollment. So now if we take a look at the intervention and the comparator, so the intervention was dapagliflozin, 10 milligrams by mouth once daily, and the comparator was placebo. In terms of outcomes, so the primary outcome included the primary composite outcome or death from renal or cardiovascular causes. The primary composite outcome included a decline in estimated GFR of 50% or more, end-stage kidney disease, long-term dialysis, or kidney transplantation. Whereas the secondary outcome included the primary outcomes as well as the composite of death from CV causes or hospitalization from heart failure and death from any cause.
So how do we approach PICO? Generally, there's always a table in the results section with the participant demographic information where all the population information can be found. So it's a good idea to create a picture in your mind of what the average person in this trial would look like compared to someone living with this condition, meeting the criteria outside of the trial. Both the intervention and comparator are listed in the methods section, and there's usually a table of what the primary and secondary outcomes are as well. Quality of the study is dependent on various factors. You would consider randomization, blinding, concealment of allocation, and intention to treat, which DAPA-CKD trial was in all of these things. The percent lost to follow-up was 12.7% for the intervention and 14.4% for the control. And this trial was supported by AstraZeneca.
So like Jasmine mentioned, the DAPA study was double-blinded, randomized study with concealment of allocation, and it was conducted with an intention to treat analysis. So consider the loss to follow-up as well. This can also be found in the statistical analysis section under methods. Like Jasmine mentioned, AstraZeneca was a supporter and it sponsored this study, so this could have resulted in a conflict of interest. So with this slide, it's a little bit dense, but we're going to discuss how to determine the quality of a study. So we can start with if there was any concealment of allocation. So in order for participants to be randomized, allocation of concealment is required. So to find out if a study has concealment of allocation, this can be found in the methods section. And with studies, there are various types of studies, such as superiority and inferiority, and there's also different types of analysis, like intention to treat or per protocol, which can occur. So it's important to try and understand the differences and what benefits and consequences can occur as a result of utilizing which approach. So with superiority versus non-inferiority trials, superiority trials attempt to kind of just explore whether one intervention outperforms the other. But whereas with non-inferiority trials, they kind of just explore whether there's a minimally clinically important difference between the two interventions. So the next thing that we want to kind of look at is, was the study done for intention to treat or per protocol? So with per protocols, we are just looking at what would occur with the treatment effect under optimal conditions. But with intention to treat, we're kind of just more so focusing on preserving the original randomization and to try and limit any potential bias. So this is typically found within the breakdown of the statistical analysis. That's where they kind of just discuss what their outcomes are based off of. Next, we can kind of look at loss to follow-up. So this is just referring to the participants that actually withdrew from the study for different reasons, and this can also be found in the statistical analysis. So we also want to look at the conflict of interest. So this one's a little bit more tricky because sometimes it may not be directly stated, so you actually might need to determine what could have resulted in bias and whether Some areas that you can look at was like the supporter of the study, for example. You can also see if the drug company was a limitation. So it's good for the critical appraiser to just kind of think about and look for bias within the paper from the pharmaceutical company. So for example, how much did the sponsor company impact the protocol? Did they heavily impact their choice of doses and comparator agent or control over trial design, changes in protocols, and early terminations, for example? So a very key area to find more information that's crucial to your assessment and the appraisal of the trial, whether it be for the journal club or a practicum presentation, is to look at the supplemental document. So this can be the protocol or the appendix that's attached to the article. So with the supplemental document, that'll actually prepare you best for when you get asked questions about details within the study. And if you're the person presenting, it's actually a really useful tool and you should know it really well. So an additional point to consider that may not be as direct is, can the study drug actually be easily distinguished from the placebo? So this could be an area of limitation just because sometimes the drugs that are being compared, they look different. So for example, in the DAPA, they actually used oral pills, so it likely wasn't an issue. But sometimes they could be using, for example, like IV iron. So that's a dark brown solution that's being tested, and the placebo would most likely be a saline solution that's more clear and colorless. So potentially the physician that's actually administering the medication, they could be able to determine which one's placebo based off of the coloring characteristic, which could be introducing limitations.
All right, so now let's take a look at the outcomes. So the study looked at a few different outcomes to determine the efficacy of dapagliflozin. Within the primary outcome, the primary composite outcome was determined, which included a decline in GFR greater than or equal to 50%, end-stage kidney disease, which was further divided into estimated GFR of less than 15, long-term dialysis, and kidney transplantation. Additionally, death from renal or CV causes were also looked at. We will be taking a look at the hazard ratios and the 95% confidence intervals to determine which was determined for each of the primary outcomes. So if we just look at the next slide here. So for the very first one, the primary composite outcome, we see that the hazard ratio is 0.61. So the hazard ratio is less than 1, which indicates that there's a smaller risk in the dapagliflozin group versus the placebo group. And if we take a look at the p-value, it's 0.001, which is less than 0.05. So that means that dapagliflozin has a statistically significant reduction in the primary outcome compared to the placebo. If we take a look at the other outcome here, so the decline in estimated GFR, 0.53. So here again, the hazard ratio is less than 1. So this also shows that there is a smaller risk in the DAPA group versus the placebo group. And we see the same thing here with the end-stage kidney disease and death from cardiovascular causes. We see that it's 0.81. However, if you take a look at the confidence interval, it's actually 1.12. So that's greater than 1. So it actually wouldn't be statistically significant in this case.
Now moving on to secondary outcomes. So with secondary outcomes, they included all the outcomes of the primary outcomes with the addition of death from any cause and heart failure hospitalizations. So looking at the table on the next slide, we can see that there is the outcomes that were looked at were a composite of decline in estimated GFR greater than or equal to 50%, end-stage kidney disease, or death from renal causes. We also have composite of death from cardiovascular causes or hospitalization for heart failure, and death from any cause. So just looking at this, we can see that all the hazard ratios are under 1. So this actually just demonstrates that these outcomes were less likely to occur in the DAPA group compared to the placebo group. And all the outcomes were statistically significant, looking at the p-values. Moving on to safety outcomes, DAPA looked at discontinuation of regimen due to adverse events, serious adverse events, amputation, diabetic ketoacidosis, and renal-related adverse events. So these were all measured using p-values, and the statistically significant value was the serious adverse event of a p-value of 0.002.
So let's look at how to determine these results. So to determine the results of a study, most studies demonstrate their outcomes within a table format, typically table 1. This is where you would find hazard ratios and confidence intervals for the different outcomes. So our trial had composite outcomes in which multiple endpoints are combined. These are frequently used as primary outcome measures in randomized trials and are often associated with increased statistical efficiency. So consider the clinical impact of an outcome as well. What's more important, mortality or a surrogate outcome? A surrogate outcome is a clinical trial endpoint used as a substitute for a direct measure of how a patient feels, functions, or survives. A surrogate endpoint does not measure the clinical benefit of the primary interest in and of itself, but rather it's expected to predict that clinical benefit. So for example, mortality would consider death from a cardiovascular cause, while cholesterol would be a surrogate marker. A trial may find that a drug, for example, a statin, is effective in reducing cholesterol, but it wouldn't directly show that it prevents death. Therefore, it's important to consider the outcomes carefully and what the actual impact is. The benefits of composite outcomes are that they can improve the ability to detect differences in the primary endpoint. Pooling the outcomes together will result in higher event rates and increased statistical precision that will subsequently lead to designing clinical trials that include fewer patients, are less costly, and be completed in a more timely manner. Other benefits that have been reported are avoiding competing risks in outcome assessment and addressing rare instances where there's no obvious choice of a primary trial outcome. So the challenge of using composite endpoints is that the interpretation of the composite endpoints is different. There's no generally accepted standardized approach to interpretation and evaluation of a composite endpoint as if it were a single primary endpoint. And also it can be especially difficult to evaluate a composite outcome that is composed of component outcomes that may not be clinically meaningful. Combining component endpoints that have a large variability in importance to either patients and or clinicians raises substantial concerns when trying to determine the clinical impact and inform clinical decision-making.
All right, so now that we've taken a look at the results and the outcomes, we want to take it one step further and really interpret these results and understand what all of this means. So we do find that this part is probably the most challenging part of going through a study. So we wanted to walk through an example of how we interpreted the results for this study. So we're going to be taking a look at the primary composite outcome. So in this study, under the results section, specifically under table 2, which lists the primary, secondary outcomes and adverse events, we are given the AR, or the absolute risk, which is the number of events. So the events could either be beneficial or adverse. In this case, it's adverse events in treated or control groups divided by the number of people in that group. So for example, the AR for intervention, or Dapagliflozin, is 9.2%, and the comparator or placebo is 14.5%. So the next thing we look at is the ARR, or the absolute risk reduction. So in order to find this, you're going to subtract the AR from the control from the AR treatment. So in this example, you would go 14.5% minus 9.2%, which equals 5.3%. So the absolute risk reduction gives the actual difference in risk between one group and another. So in this case, from the placebo group to the treatment or Dapagliflozin group, there's a 5.3% less risk in the Dapa group of the primary composite outcome. So this was the decline in GFR, end-stage kidney disease, or death from renal or CV causes.
In terms of the relative risk, or the RR, we would calculate by dividing the absolute risk treatment divided by the absolute risk in the control group. So in this example, you would do 9.2% divided by 14.5%, which equals 0.63. Relative risk is the ratio of the probability of an event occurring with an exposure, so Dapagliflozin, versus the probability of the event occurring without the exposure, so the placebo. So in this case, the RR was less than 1, and the confidence interval does not include 1. So events are significantly less likely in the treatment than the control group, which is a good thing because we're looking at events such as GFR decline, end-stage kidney disease, or death from CV or renal causes. Then lastly, for numbers needed to harm, so NNH, you would calculate by doing 1 divided by absolute risk reduction, or ARR. So in this example, it'd be 1 divided by 5.3, which is 19. So numbers needed to treat is how many people need to receive a treatment so that one patient would be expected to benefit. In this trial, the number needed to harm is a relevant factor to consider, as it tells us how many patients must receive a particular treatment for one additional patient to experience a particular adverse outcome. So in this case, how many people would need to receive dapagliflozin in order to avoid or reduce the risk of their primary composite outcomes. So you would do this for all of the outcomes to really understand what effect the treatment group had on the outcomes as well.
So now we're just going to be talking about the limitations. So the limitations that the author stated within the study was that the trial was stopped early. So this could have an impact on the statistical values as it could reduce power. But because there's a strong internal and external validity, this would actually suggest that the limitation associated with it is unlikely. So additionally, after the completion of the trial, the participants' eGFR was not collected. So we're unsure what the GFR values became after the trial was over. With some limitations that we considered was that approximately 97% of participants were on an ACE inhibitor or an ARB, and 65% were on a statin. So this could potentially have influenced the efficacy of the outcomes surrounding cardiovascular events and CKD progression. But another side that you could look at is that the therapeutics for this population will already be on these medications anyway, so this could be a limitation or an applicability issue. While DAPA did include patients under a GFR of 30, the majority of the participants actually enrolled in the study had a CGA staging of stage G3B and an ACR of A3. So the ability to actually generalize the outcomes may be limited. And lastly, the involvement of AstraZeneca is a limitation, as this could have introduced some bias surrounding the efficacy and or safety outcomes. So now we're just going to determine how to find limitations. So some studies actually might have a section that discusses the limitations of the study. That was the case with DAPA, but this might not be the case for all studies. So for these type of articles, you'd actually need to keep a lookout for anything that could introduce any form of bias, such as the sponsors of the studies, other medications the participants may be taking, and other medical conditions, and anything else that we mentioned previously.
All right, so now let's take a look at the conclusions for both the authors and for ourselves. So for this study, it was shown that CKD patients on dapagliflozin had a decreased risk of primary composite outcome than those on placebo, and there was a lower risk of death on dapagliflozin than those who were taking placebo. Additionally, the trial was stopped early, which is a good indicator that there is a benefit with dapagliflozin, which helped us come to agreement with the author's conclusion. So in terms of reviewing the conclusion, so in the article, the conclusion can be found both in the abstract as well as near the end of the actual article. So this is where you can see the overall endpoints of the study and what was concluded from the study. With conclusions, it's important to always use your own judgment, as sometimes you may not agree with the overall conclusion. And it's also important to explain why you came to that decision.
So in terms of the clinical implications, some other areas of study we think should be addressed is that the results are consistent with previous trials that also looked at the benefit of SGLT2 inhibitors on CKD, such as the Credence trial that we previously mentioned. And a study on dapagliflozin's effect on heart failure showed similar benefit to that in CKD as well. So the cost of SGLT2 inhibitors is very expensive, and special authorities only granted for inadequate glycemic control on other therapies for diabetes. So this can be a very important adherence concern for patients that needs to be considered. Additionally, tolerability is an issue, as side effects are present, such as postural lightheadedness and UTIs as well. So you want to consider the cost effectiveness. Ask yourself questions like, how much will this medication change my patient's quality of life? In addition, ask yourself if these results are generalizable to the patient that's standing in front of you. So we've provided a resources slide here. You may or may not be familiar with the document created by PEAC and PTALC. It includes a form and a summary of 4 pages of, like, it's fillable. So it's like how to critically appraise, as well as what some of the factors actually mean. There's also NerdCat. We didn't link that here, but that may be a valuable resource. It's organized by the type of study. And that brings us to the end of our time. Thank you for listening to our presentation. We hope that you found it helpful. We'll pass it over to Blair for any additional comments and tips that he might have about critical appraisal, after which we can take questions on the trial.
Yeah, first of all, thanks so much. That was really thorough job, really went through all the aspects of the trial and really breaking it down. Helpful event. I wish I had something like this in my first year, would have really helped. So glad to see that. I think if I wanted to add like one thing, I think maybe I misread it, but on allocation concealment, I think the wording might have been backwards, where like allocation concealment is required for blinding rather than like blinding being evidence of allocation concealment. I think just to talk a little bit more about allocation concealment, because I don't think it's super intuitive. It's basically if like you're enrolling someone in a trial, can you actually like predict which arm they're going to end up in? So they might have say like random envelopes. So it's randomized. They have like a randomized system. However, like if the envelopes were like transparent and you could like hold it up to the light and see like who is getting what, not only could you decide who gets in which arm, you could also, you'll know which arm they're in. So then without allocation concealment, there's no blinding. So I think that was just one thing. I think other than that, I think one other thing I'd emphasize is just when looking at the outcomes, and you kind of touched on this, but not just looking at whether it's statistically significant, but asking whether it's going to be clinically significant. Like in this trial, we're talking benefits, primary composite outcome of about 5%, but then also looking at the components, as you said, and like the most important component of death from CV cause was the one that wasn't statistically significant. So kind of just thinking about how does this really relate to the patient. You kind of touched on it with the surrogate outcomes, but I think that's really important in informing the bottom line. I have some other really small things, but overall, really great job. And I can add in more things later, but I'd rather open it up to questions and discussion.
I actually have a question and just one addition to add on there. On the last couple of slides, you guys talked about DAPA and special authority. This is just a little tidbit now. It's actually approved for HFrEF patients as well. It's like one of the newer criteria. So if you guys take a look into that, if a patient kind of has HFrEF and a comorbidity, you can add that on as well. And I'm not sure if I missed it on the slide where you guys kind of talked about, patient characteristics of the trials. Did you guys report like how many actually had type 2 diabetes? And why do you guys think reporting significant characteristics like these are important for relating it back to your patients?
Yeah, I can answer that if you just want to pull up the slide. I think it was 60 something. Or sorry, like 60 something percent, but yeah, one more. There we go, that one right there. So yeah, for comorbidity, so 67% of the population have type 2 diabetes. And so in terms of like why this would be relevant, it's just looking at, so for dapagliflozin in CKD, like would somebody that has CKD and are they likely to also have type 2 diabetes? So in this case, I think it would be relevant as well. So that's why you always kind of take a look at their comorbidities and even the medications. And that's something that Hadr touched on as well, just in terms of like the ACE inhibitors and ARBs and even like the statins as well. And this is something that you would typically see a patient with CKD take those medications and these comorbidities as well. So
Thanks.
I'll pose a question based on like that. So 65% of patients were on statins in this trial. So do you think, okay, I have a patient who's not on a statin. Do you think is that going to change your clinical decision-making at all?
No, I think I can kind of put my insight on that. I think it would also really depend on what other comorbidities they're kind of presenting with, overall picture of my patient, and like their life expectancy and everything like that as well. So if you kind of had a patient when you do like the Framingham risk score and all of these things, and you see that they're higher at risk, And, I'd hate to say it, but unfortunately they might not live that long. Putting them on something that's so expensive, if they don't get the coverage for it, might not be the best option. So that's kind of more of like a conversation I would have. But actually considering, I think, if this showed like a clinical benefit and this is something that my patient really wanted and we kind of went over it together, then I would see no harm in that as well, if they were okay with the cost and everything. But that, I think, is a more a little more of the gray area that you kind of have to have those like difficult decisions with your patients, and have those conversations to kind of see, what are we actually trying to get out of this? I know it's really easy to kind of have it as like a DTP and just be like, yeah, that's something I have to add right away. But actually looking at like the cost versus benefit is a huge thing.
Also, just to add on for the statins, CKD is a statin indicated condition. So I think it would be super important to ask like why they're not on a statin, and just kind of have that shared decision making between you and your patient, because if they're not on a statin, there's hopefully there's a reason why, and if they might be interested in starting it as well.
Yeah, definitely. With all that was said, I think I also want to get at, like, do you think that this drug works in patients not taking a statin?
Yeah, the efficacy shows that SGLT2 inhibitors do help in patients with CKD. So yes.
Yeah, even though the majority of patients were on statins in this trial.
Exactly.
You don't think that's a problem?
Okay. No, but it's just something that we should be mindful of. It's not necessarily because of this SGLT2 inhibitors don't work, but just something to note, and just it could be a limitation, but like we mentioned, it could also just be an applicability issue. But for the majority of patients, just based off of their progression with CKD, it did seem to have an improvement with their GFR.
Yeah, definitely. I think what I was trying to get at, and I think you understood that, was like, you can still give it to the patient with statin, because really asking, like, if my patient doesn't meet the picture of the patients in this trial, is it like a really important reason? So I don't think, like, say, dapagliflozin's effect is somehow mediated by them being on a statin. Whereas if they didn't meet some other criteria, I might be more worried. For example, if they weren't in the eGFR range, like say they were too low, I might worry there might not be a benefit. Well, also safety concerns with SGLT2 inhibitors, but also just like, okay, they're almost already at end-stage renal disease, probably not a benefit there. If they're above 75, not a benefit there. So I think really going through the inclusion criteria and saying, like, if my patient doesn't match this, does it actually matter in terms of the effect? So like, say, statins would be one that I wouldn't hesitate, if they're not on a statin, to say that this trial somehow doesn't apply to them. But there are some other criteria where if their age was way off, say they're quite a bit older, and I think we're talking about prognoses, kind of relating that back to it. So.
Any other questions at all? Or if not, then any other comments, I guess? Lisa.
I guess going off of we were just talking about renal function too. So this study, like the lower end was 25. So what do we think about using it in those patients? Because I think right now the recommendation is still like no less than 30, right?
Yeah, that's correct. But the interesting thing about this study was that they included patients under 30, which was something that the other studies didn't touch on. I think the recommendations right now is, like, if they're on dialysis, to not start them on an SGLT2 inhibitor. But I think that having done this study, it shows that there is still a benefit. And I think there's still areas where research needs to be done to just determine the safety of it all. But it's definitely a step in the right direction in terms of seeing what is beneficial for those patient populations.
Yeah, great job, great presentation. And I think there's also a trial coming up for EMPA, supposedly this year. And they also include patients with lower eGFR too.
I just wanted to add on, how did you guys find, this is like not about this study, but more so in your process. How did you guys find, like, you know, using the templates and things to kind of navigate your critical appraisal? Like, do you guys recommend that for first and second years who are going into their the critical appraisal IAs, or do you guys have a specific method of your own? Any like tips or tricks that you guys would recommend?
So I find the PEAC and PTALC fillable forms super helpful. I use it for like every IA that we get a chance to, and we used it for this one as well. I just think it like lays it out very simply and then gives you all the relevant definitions from like it's a very basic but like comprehensive form. So I find it useful. That's my favorite. I know there's other ones out there.
Yeah, at first it can seem really intimidating to try to appraise a study, but it definitely lays it out for you and it's really helpful. And I know that in first year I was using it a lot too. So definitely recommend.
If anyone has any additional ones that they use, feel free to like link them or share them. And maybe we can make a list or something for first and second years or third years too.
I guess at this point, I will plug that me and Ricky Turgeon co-authored the new NerdCat textbook that comes with checklists for doing this. So if you're interested in using our open source textbook, I'll put that in the chat. Also comes along with like a whole textbook on why you're doing all those things. I started out using the PTALC PEAC form. Maybe if you're on hospital rotation and want to go like a bit more in depth, once you start get a little bit more comfortable with things, resource probably more helpful. It's getting integrated into your curriculum anyway, so you'll get forced to use it.
Blair, I think there's just a comment in the chat from Erin, if it's okay to post it on the PEAC website.
Oh, absolutely.
Dr. Bull, I don't know if you have any comments or suggestions or tips at all. You can go ahead if you do.
I don't think I have anything additional. I think you guys did a fantastic job reviewing a standardized way of doing critical appraisal. And I can't speak enough as a preceptor. Those skills are so important. Every time you come to your preceptor to discuss an idea, an option, a DTP, it's always going to go back to your critical appraisal of where that evidence comes from. So I think having one of these standardized methods that you're familiar with, you know very well, will be very important entering into your rotations and discussing your recommendations with your preceptors. I think it's fantastic.
So thank you for that, Dr. Bull, and thank you to everyone for coming. If nobody has any other comments or suggestions or any questions at all, we can actually head out. I know Hadra has a PED session right after this. So yeah, thank you guys for coming, and thank you, Blair, for being our expert. We'll probably post a recording on the PEAC website, so keep an eye out for that.
Thank you.
Thank you.